My name's Ines Rio. I'm the GP liaison, head of the GP liaison with the Women's, and welcome to this session this evening of bleeding in pregnancy. I'd like to start off acknowledging that wherever we are, we're meeting on the lands of the First Nations people and pay the respects of myself, Northwestern Melbourne Primary Health Network, also the Royal Women's Hospital, to lead the leaders and to First Nations people. I'd also like to thank the team at Northwestern Melbourne Primary Health Network that have assisted us put this event on, and particularly Sadia and Selena. Just a few housekeeping issues. All attendees are muted. Please ask questions via the Q&A box. There's a Q&A box and a comments box, but if you could ask questions via the Q&A box. The session is being recorded. Please ensure you join the session name using the name that you've actually registered, because the team at Northwestern Melbourne PHN use that to actually mark off your attendance. So there's a little picture here on the right as to how you change those name if required. So here it is. How you change your name if required. To change your name, click on the participants button at the top of the Zoom window. Hover your mouse over the name of participants list on the right side of the Zoom window. Click on rename and enter the name that you've registered. Thank you for that. During the session, later on in the session, there'll be a link to a survey and an evaluation form. So if you could complete that, that would be terrific. In approximately a week, you'll receive the PowerPoint and the link to the recorded session. This session actually gives you 3 RACGP CPD points, and they're pregnancy related. And that evidence will come up on your CPD statement in about a month. There are also 2 other upcoming webinars that we're holding. Each is eligible for 4 pregnancy CPD points. They're being held between 7 and 9 o'clock at night. One's on Wednesday the 19th of October on COVID and pregnancy by Vicky Woodward at Women's, and third trimester issues by Rachel Warren. They're both heads of units, just as Peter's head of one of the units, Vicky's head of the unit, as is Rachel. On Wednesday the 26th, there's a talk on gestational diabetes and pregnancy and third trimester issues by 2 of the Western team. I'll put those links in the chat for you to register and to seek those details. Just a reminder about re-credentialing for GPs at the Royal Women's Hospital, Mercy Hospital, Western Hospital and Northern Hospital. You only need to re-credential at one site and tick the boxes for all the sites. Information will be emailed out in early October, and you need to provide evidence of 5 hours of pregnancy-related points, so 10 points. As I said, 3 points are applicable tonight. You'll need to show evidence of medical indemnity and agree to undertakings. There's the 2 webinars again. And prior to just introducing Peter, the session for today will go for about an hour. So Peter will have a PowerPoint for about an hour. If you have questions during the presentation, please put them up on the Q&A. And if there's a thematic analysis, I'll sort of, a theme, I'll interrupt Peter and ask the questions. Towards the end of the hour, Peter's got some cases and clinical conundrums, and then we'll open it up more broadly for Q&A. So just an introduction about Peter, who I have great pleasure of working with at the Women's. After graduating with honours in 1993, Dr. Cervical undertook specialty training in obstetrics and gynaecology until 2001. His training included 2 years of maternal fetal medicine subspecialty and 6 months of urogynecology surgical enhancement training. For more than 20 years, he's practiced obstetrics gynaecology both privately and publicly. He is currently a supervisor in the obstetric training program at the Royal Women's Hospital. We're delighted to have him here today. So thank you very much, Peter, and I'll stop sharing. Over to you.
Okay, I'll just put my screen up. Ines, thank you so much, and thank you everyone for joining in this evening. I've been tasked with talking about bleeding in pregnancy, which clearly is a big talk, considering it spans the 40 weeks from the beginning to the very end. And I hope that you'll be able to gain some useful information out of this and some, I guess, some tools of the trade, so to speak, in working out how to best manage, when to pass on the care and so on. Okay. Excuse me, sorry, I'm just kicking off. There we go. So the aims of the talk. How often do women bleed in pregnancy? What are the causes? And we're going to focus on gestational specific conditions. So focusing on the trimesters of pregnancy, the 3 trimesters, which are usually that 13 or 14 weeks each trimester. The value of history and examination, how we are trained as doctors in the provision of care and the way of coming up with a diagnosis. What investigations are useful and when to do them and how to do them. And how do we prognosticate, when someone is bleeding? What do we expect from the bleeding in terms of the outcome to the baby and to the mother? How do we treat the bleeding? How do we keep both the mother and the baby safe? When do we involve an obstetrician, such as myself, my colleagues? When do we refer into a hospital, be it a public or a private hospital, various emergency departments, etc.? And when is admission required? And of course, in the midst of all of this, remembering the important anti-D, which is a great masquerader for us when we do exam topics with our trainees and we throw them a curveball case, and commonly the patient will always be rhesus negative, and the role of anti-D in protecting against rhesus immunisation after the event. So the first question that was brought up was, how often do women bleed in pregnancy? So in specific terms, and this is across all formats from public, private, the Women's Hospital, Australia, even international data, on average, we expect bleeding to occur around 20 to 30% of all pregnancies. And so if you think about in Australia, in the year past, where there were 290,000 babies delivered, and there would have been a percentage of those that were multiple births. But if we were to limit that to, say, 289,000 or so babies born, and up to 25% of them, as evidenced by the Women's Hospital data, 1/4, that is a large number of women who are experiencing bleeding at some stage in their pregnancy across the country. And the presentation in terms of the word bleeding, when a patient might ring you up with bleeding, will vary from very simple loss, so what we would call brown discharge, but nonetheless we would call that blood or brown blood, through to frank bleeding, which can be menstrual in nature, and even in cases it can be genuinely life-threatening. And that sort of catastrophic loss of blood, depending on the gestation and the cause, and of course previous spring to mind, can be really quite significant. And even today, in the context of the work that I've been doing the ward service at the Women's and also with my private practice, I had 2 addition patients today in my private practice who'd had spotting in early pregnancy that required review. And we're dealing with 2 quite significant preview inpatients at the Women's Hospital with very significant consultative sort of setups for urology, MRI, hematology, etc., with a view to doing potentially quite significant Caesar hysterectomies in the coming weeks for what will be, potentially very risky Caesars for these women, and in the context of the bleeding that they might have. We will talk, with the issue of pain and what is the relevance of pain when someone bleeds. Is it going to happen in all patients when they bleed? Is it actually prognostically useful to guide us as to what might actually be happening? And I guess the adage here, of course, is that a woman who presents with a spot of blood in early pregnancy, you might say, well, then probably they're not going to be experiencing a miscarriage. But someone presents with slightly heavier bleeding and pain, you'd be more concerned. But is that actually always the case? And really importantly for me is that not all bleeding will lead to pregnancy loss. And when I make the comment here about this layperson specific language that's really important when we counsel our patients, the way we see our patients, how quickly we can see them, the way we examine them, the way we ask the questions, and some of the language that we will use, and I'll allude to this in another slide, can be very relevant to managing their anxieties and their concerns. And if you think about some women nowadays where we're seeing an ageing population, we're seeing women coming in with more assisted reproduction. If they have some bleeding, it's catastrophic in their mind, and thankfully not always the case. And the way that we speak to them and the way that we discuss what's going on can be really important, not just for their physical care and the outcome of the pregnancy, but also their emotional care. So I mentioned at the start the issue of gestational specific bleeding, and so I allude to the issue of the trimesters of pregnancy, which we're familiar with. So the first trimester from first 14 weeks of pregnancy, remembering that usually the positive pregnancy test that you would do at home would be no earlier than the 3.5 to 4 week mark. So that 10 weeks from there. The second trimester, the 14th to the 26th week, and then of course the remaining third trimester, the last third of the pregnancy, all the way through to the 40th week or term. And in terms of the, I guess, the words that we use in the context of the bleeding that might occur, first trimester bleeding is usually referred to as a threatened miscarriage, whatever that moniker might be. And then a second trimester bleed, depending on the gestation, for example, up to the 22nd or so week, would be referred to as a threatened miscarriage as well, versus after that where we use the nomenclature of antepartum hemorrhage. Okay. And then the third trimester would be, with any bleeding that would occur, we would refer to as an antepartum bleed, an antepartum hemorrhage, or of course the nomenclature of show, so the operculum plug, the passage of the mucousy bloody show that will occur in very late pregnancy, particularly in multis and certainly in primaries as the cervix starts to ripen. The point to make, which I mentioned in this last paragraph, is that outside of the use of those terms, threatened miscarriage, antepartum hemorrhage, show, the terms are not necessarily useful because there really will be very many different causes and different prognoses, and as such different managements for the different bleeds that might occur in each of those trimesters. So when I used in the previous slide the comment about being very particular with our use of words and the way we discuss things with a patient, if we said to a woman, oh, look, you're 8 weeks, you've had a spot bleed, you've had a threatened miscarriage, that will resonate very, very, very strongly to someone who, as I said, is a 40-year-old IVF patient who's maybe had several miscarriages in the past. And whilst every pregnancy is special, this is particularly special, and the word miscarriage is the word that she'll hang on to. And if perchance we were to examine the patient and she has a perfectly normal pregnancy and sac and gestation and a florid ectropion with contact bleeding with the speculum on examination, almost without question the cause of the bleeding, we have used a word, threatened miscarriage, which really isn't necessarily contextually appropriate for her situation. So how it is that we individually choose to speak to our patients is obviously a personal choice, but whilst I mentioned on the slide the various names I've mentioned, I think we can all agree that there's probably a degree of common sense in the specific wording that's really appropriate for our patients. So I use the words tonight in a medical forum, but for our patients, we might need to be a little bit more considered. So let's look at the first trimester. And what I've essentially done is just listed what the different causes of bleeding may be in that first 14 weeks of pregnancy: mild, heavy, painless, painful, etc. So I've used the word threatened miscarriage. So a pregnancy that might be possibly threatening to miscarry, but is still viable. There is implantation bleeding, and with implantation bleeding, essentially the theory is that the uterus is a very thin cavity with length to it, and really for most people it would be smaller than the size of your fist in the non-pregnant state. And then obviously once a fetus is developing within the uterus, the gestational sac is going to, I guess quotation marks, fill up all the nooks and crannies of the cavity of the uterus. And as the placenta starts to establish itself, there is an ingress of blood vessels to support the conception and the baby grows thereafter. But as you imagine in that early phase, as the sigillized endometrium, the pregnancy-induced endometrial lining of the uterus is changing and the sac is incorporating into the various nooks and crannies, you can imagine that there could be a little aberrant blood vessel which bleeds and leads to what we commonly see on ultrasound reports, an extracoronary clot, a retrocoronary clot, whichever nomenclature they use. And so we might see that as an implantation bleed. And pleasingly, thankfully, most of the time will self-correct, stop, dissipate, and not cause any problems to the pregnancy, but obviously can be alarming when seen. Then, of course, there is a miscarriage. So a miscarriage in simple terms is a pregnancy that fails under 20 weeks. So whether it's an early miscarriage or a late miscarriage, but anything that happens under the 20th week or based on the various guidelines we have in relation to the baby's weight, etc. at the time of the delivery, but under 20 weeks, under 400 grams, would be a miscarriage. But miscarriages can have, there are types of miscarriage. So the blighted ovum, which is the sac where there's no fetus developing. So essentially you're really just developing the trophoblastic shell around the outside, but the sac is empty, there's just fluid in it. And quite disappointingly, those sacs can sometimes grow gestationally appropriately. So 6 weeks, 6 week sac, 8 weeks, 8 week sac, 10 week sac. The woman experiences a whole number of normal pregnancy symptoms as the corpus luteum is continuing to provide that support for the early pregnancy until it establishes its own placentation. And yet there is no fetus there. And almost always they are going to be genetically worrisome causes behind that. Missed abort is where there's a fetal pole, but there's no fetal heart. It might be picked up literally not long after the miscarriage. So an 8 week fetal pole at 8 weeks gestation based on last menstrual period, but no fetal heart. Or it might be that a woman presents bleeding at 9 weeks and the ultrasound scan shows a 7 week missed abort. So the heartbeat stopped clearly 2 weeks ago. Disappointingly, they were unaware of that. They might have had ongoing pregnancy symptoms. They had no bleeding. There was nothing to suggest there was an adverse outcome until the ultrasound scan shows the pregnancy hasn't progresses. Complete miscarriage is where there's a complete passage of the trophoblastic tissue, and incomplete is where there is an incomplete passage of the trophoblastic tissue. And the first one would be a pregnancy that has basically passed itself, and from the woman, very disappointingly so, but of course, no requirement for any therapeutic intervention. And whereas an incomplete miscarriage where there's still trophoblastic tissue, albeit usually just in, I guess, clumps of tissue, that may possibly require, if there is a bleeding issue or a concern, a possible consideration towards curette to remove those remaining products. An inevitable miscarriage is where you've got a gestational sac within the cavity, presumably with a fetal pole and a fetal heart, but the cervix is open. And when a cervix is open at that early gestation, there is nothing that we can do about it. Like, it's not appropriate to put a cervical stitch in, and that would be expected that that pregnancy will probably pass inevitably with no control. And of course, GTN is the acronym for gestational trophoblastic neoplasia. So we're talking about your molar and your partial molar pregnancies. And ironically, as I was just preparing to put the slide up tonight, I had a patient who was literally my second last phone call of the day, who's just been diagnosed with a partial mole. And there are some implications for her in relation to how that will need to be managed in terms of beta-HCG follow-up and so on. And as a very quick sidestep to this, if perchance you ever are involved in a pregnancy where there is a molar pregnancy, be it a molar complete or a partial mole, the best thing to do is just to refer into the local maternity hospital or to an obstetrician. We have a gestational trophoblastic neoplasia register in Victoria, so they basically put onto a database, and that allows for very, very succinct follow-up of the patient in relation to the beta-HCGs they'll need, curating they're required, any potential for therapeutic intervention if there's concern about progressive disease into sort of more significant invasive trophoblastic neoplasia. It's almost like an entire conversation itself as far as a presentation.
Peter, just a comment on that too, just from a GP point of view, it's really important in that instance for the following pregnancy that an early scan's actually done as well, because often that's in the purview of the GP.
Yeah.
And if a woman doesn't get a follow-up beta-HCG 6 weeks postpartum, it falls onto the GP as well. There's a question that I've got here about the use of the term abortion as opposed to miscarriage, if you could comment on that.
Oh, look, I don't know perchance if there's any particular commentary out there in terms of from both our hospital and also in the greater large in relation to whether that is the appropriate use of wording, miscarriage versus abortion. I guess we all associate abortion, the word, with a therapeutic abortion, so actually an end of pregnancy planned. But in terms of nomenclature that is used in all the books and so on, when I mentioned missed abort, complete, incomplete abort, inevitable abort, that's the terminology that's written up in all the textbooks and so on.
Thank you.
For those of us who still use textbooks. Ectopic pregnancy must always be considered. Generally speaking, ectopic pregnancy is normally going to present either as a diagnosis on scan, as maybe an early gestational scan was performed and it's noted that the pregnancy is not in utero, or as a person who presents with significant pain and or obviously, hypotensive sort of shock crisis from internal bleeding of the the pregnancy is ruptured, particularly if it's in the fallopian tube and it ruptures intra-abdominally. But you can get some ectopic pregnancies that will present with bleeding. And interestingly, when we use the word ectopic, it means a pregnancy that's not in the uterine cavity. So whilst the vast majority of them will be in the tube, you can get some in the ovary, but you can also get some in the cervix. And an ectopic pregnancy in the cervix presents us with an interesting clinical conundrum in management. And on a side note, actually, some years ago, I wrote a paper on the topic as a way of managing what is a potentially difficult problem, recognising that your uterus is a big ball of muscle. And when a miscarriage occurs, if you do a curette, in whatever capacity the pregnancy fails, the uterus is a very good organ at contracting down, constricting on those spiral vessels that are coming through the myometrium and essentially stopping the bleeding that's ensuing. But the cervix is essentially all connective tissue. And when those pregnancy enlarged vessels that are coursing through the cervix have the pregnancy taken off, say for example, if you did a curette and remove the ectopic off the cervix, the blood vessels coursing through the cervix have got no capacity to constrict down. And so you can get quite significant bleeding from a cervical ectopic. And the reason I wrote the paper was because we had an unexpected cervical ectopic once under our care, which led to quite significant bleeding, which ultimately we're able to thankfully control, but not without quite significant blood loss. And it prompted a really strong review of the literature and a contemporary approach to how we treat that. And we've got different ways of looking at this problem now using things like chemotherapeutic agents and vascular suppressant agents and so on. And again, another topic in itself. Cervical congestion. I alluded to a case earlier where the speculum revealed a very large cervical ectropion. And cervical ectropions are very prominent, particularly and very common rather in pregnancy because of the hormonal nature of pregnancy and the way that the cervix almost mushrooms out on itself. And if the cervix is made up of the squamous epithelium, which is multi-layered and thick like skin, but the ectropion is made up of basically single-layer columnar cells over the basement membrane with the underlying blood vessel, you only have to brush that cervix briefly and, of course, you're onto the blood vessel and it bleeds. And so you can get quite significant bleeding from the congestive changes of a cervical ectropion in pregnancy. And it's almost relieving to see one when you're examining a patient who presents with bleeding and then you do a scan and see the baby as well, because you can very confidently say it's very unlikely the bleeding's from the baby, it's from your cervix, so the baby's fine. And the cervix itself is still healthy, it's just got a very raw outer surface. There are, of course, other pathologies to think about, cervical polyps as an extension of a cervical ectropion. People can have vaginal and labial lesions in whatever capacity they are, tumors, polyps, etc. And when I use the thrombophilia, I'm not talking about blood clotting thrombophilia, so not your prothrombin gene mutation, not your factor V Leiden, etc. What I'm referring to is someone who might have a haemophilia type bleeding disorder, whether it be a platelet coagulation disorder or a von Willebrand's type disorder or something of that nature. She might be a haemophilia carrier even though she's a female, and that can occasionally lead to bleeding. So this is just some of the things that we should always be thinking when a person bleeds in the first trimester, with really the most common causes being the ectropion, a miscarriage, or a threatened miscarriage, which would really be under the guise of maybe an implantation bleed. So they're the ones that are mostly likely going through your mind as causative. Second trimester, again, using words, but the threatened miscarriage is really up to that the 20th week, so the late miscarriage versus the FDIU, and the difference between the two is based on gestation and size of baby. And the difference for us really comes down to then obviously, amongst other things, the underlying causative, but also paperwork requirements, because anything, whereas after 20 weeks, 400 grams is going to become a registrable neonatal death and will require an appropriate review by the consultative counsel, and you have to make sure that you've done all the appropriate investigations for that. Cervical incompetence. I'm going to talk a bit more about cervical incompetence lately, and in fact I'm dealing with a number of personal patients with this problem at the moment, but also a number of patients up on the ward at the moment with ward service. And with great dismay yesterday, we lost a triplet pregnancy at our hospital at 18 weeks due to cervical incompetence, and incredibly frustrating as a clinician because there was nothing to do that we could do to stop it. Here we are in one of the world's leading tertiary hospitals and we had no control over that situation. cervical congestion, and here again the issue of postcoital bleeding. So if you've got a raw cervix and you put a penis into the vagina and the penis brushes the cervix and it's got that thin columnar layer, of course that can bleed. So the good news is for patients when they have bleeding with intercourse is they all come in panicking thinking they've hurt the baby. 99.9% of the time that'll be postcoital bleeding from the cervix, and the baby will be absolutely fine, because most cervices are going to be in excess of 2.5 and dare I say over 3.5 centimetres long. So the baby is far removed in the cocoon of the uterine cavity. You can have early onset placenta previa bleeding, and I'll talk a bit more about this on the next slide, but placenta previa bleeding for a low-lying placenta, because we need to remember that about 15% of all pregnancies will implant in the lower segment. And then what happens with the growth of the baby is the uterus then pulls up from the cervix. The placenta is attached to the uterus and then pulls away from the cervix as that happens. So it's not the placenta actually moving, it's the placenta gravitating away under the growth of the uterus with the growth of the baby. And so only 2% of people have a placenta previa at full term. But placenta previa bleeding in early pregnancy can happen, and obviously there are challenges in how to manage that. Placental abruption is where you have a separation of the placenta off the wall of the uterus, and whether that is painless or painful, and whether it's mild or significant. The one probably most daunting thing about it is that when it occurs, there is no medical solution to stop it. It's the same with placenta previa bleeding. We can't stop the bleeding. We have to make decisions about the baby's safety, the mother's safety, when to admit, issues in relation to the gestation and questions around steroid loading and so on. So placental abruptions that occur early, and the investigative process required if that ends up being an end of pregnancy event, there are very specific processes that we would go through to work out why that happened. Does the woman have a clotting disorder or an early onset preeclamptic risk, which has led to infarctions in the placenta, which have then led that to happen? Do we have a mother who is drug abusing? So obviously your methamphetamine, cocaine use, which can stimulate this to happen, the smoker. Is there a previous risk factor of some other nature? And so we investigate very heavily for when this occurs, but more importantly, when it actually does occur, it's how do we actually help the mother and the baby at that moment? There are, of course, going to be the other local pathologies, which I alluded to in the other slide, the thrombophilias, dare I say, hemophilias, and then, of course, we always need to remember trauma. And trauma, of course, leading to the placental abruption, and the ones that we see mostly from a trauma cause are the big significant motor car accidents with seatbelt trauma or steering wheel trauma.
Could I just, Peter, there's a very common issue in general practice, which is the subchorionic hematoma in early pregnancy.
Yes.
So there's a question about, do you need to do is it predictive of anything?
Yep.
And do you need to follow it up with another?
Sure. So a fantastic question, and this is the annoying thing about the nature of our work. I often use this analogy with patients that in life, if you have appendicitis, it's a terrific diagnosis in the sense that you have it and you just say you have to have an operation to fix this problem. There's nothing else. But when someone presents with bleeding in pregnancy, there's a million different things that can happen in terms of why it's happened and what you can do about it and so on. So there's not a one-size-fits-all answer to your question. But when you see a subchorionic hematoma, and we'll allude to the ones that are hopefully not too big, and also the ones that are occurring in early pregnancy, and also ones that sometimes we see not near the cervix. For example, if you had a 7-centimetre subchorionic hematoma near the cervix at 17 weeks, you're concerned about getting an ascending infection that creates a nidus of infection with a large clot that could then lead to intrauterine infection and problems. But if you've got a 3-centimetre subchorionic hematoma or 1.5-centimetre subchorionic hematoma at 8, and I've talked about how maybe that's because the sac didn't get into all those nooks and crannies and there's a little blood vessel that's popped, and much like when we cut our skin, eventually it coagulates, we're assuming that that will stop. We're assuming that that will disappear with time, and we'll assume that has no problem for the baby. But because we know that when a person miscarries, 85% of miscarriages, there is usually a genetic anomaly associated with the baby. And the other 15%, there might be some other underlying cause, which we wouldn't investigate in a first pregnancy, but for someone who's a recurrent miscarrier, we would. Thrombophilias, autoimmune disorders, lupus, severe thyroid disease, even severe cases of celiac, etc. Again, this is for the recurrent miscarrier. So the answer to your question is if you saw it, Yes, I've noticed it. Yes, that is a risk factor for potential failure of this pregnancy, potentially getting bigger, but most of them actually dissipate. Most of them actually won't cause a problem for the baby. So that in terms of that language that we use with our patients, I am usually cautiously optimistic, not worrisomely pessimistic.
So in the general practice setting, it would be frequent that you would see it at, your first ultrasound at 8 weeks or something like that. And would you counsel GPs if it's I'm not sure what a big size is, so that would be interesting, but to maybe redo it at, 2 to 3 weeks' time?
I think the wonderful thing about contemporary obstetrics is the wonderful access to scanning. And I have 2 scanners in my room, an older one for basic presentation, check the heartbeat, just visually see that the AFI looks normal in late pregnancy. It's just a nice little tool for the parents, and parents love it. You do a Doppler, they hear the heartbeat. You can show them the baby, they love it. But in terms of having a proper ultrasound machine where I can do intravaginal and abdominal scanning at early gestations as early as 5.5, 6 weeks with fetal Doppler and so on, and able to measure the length of the cervix, measure the gestational sac, the extracoronary clot, etc., it makes life so much easier. So when a patient rings you up, I'm very blessed to be able to say, you know what, just come in and I'll do a scan. I see lots and lots of women who really, they could have maybe waited another week or 2, but they're so anxious. The scan is very reassuring. It's placebo as well, because as we know, scans aren't therapeutic, they're diagnostic. Scan doesn't make the pregnancy better, it just tells you what's happening at that moment. So if a person has an extracoronary clot in general practice, and you've just organised them a scan, and obviously you're not doing that scan yourself, so outsource that scan with a dollar value associated to that scan.
And often that is a real impediment for our patients.
Absolutely. And so, look, for me, it's a luxury. We obviously, as obstetricians in private, we have some out-of-pocket components to care for private care, but the individual-based appointments, when they come in, I just do that scan, it's free. I mean, if they have 10 scans in the pregnancy, they'll have 10 free scans. And that's a luxury that I have. And I always tell my patients, don't go and get a scan outside if you don't have to. I'll do it for you. Because it would be... And
the reality is, I suppose, is, in lots of cases, it's not going to change management because you're going to do another scan at 12 weeks anyway.
Correct. But it allows me to give them good information straight away, to reassure them, hopefully. And also, God forbid, if it is a failed pregnancy, I can instantaneously counsel and deal with it. But in general practice, the answer to your question, it's a long-winded answer, is I would say if you've got an extracoronary clot with no further concerning bleeding and you're comfortable with things, I just get a repeat scan done in a fortnight, because that's what the woman would want. She would be anxious and she would want that. If it coincides with the NIPS test, if it coincides with the 13-week nuchal translucency scan, all the better.
Right. Yeah. Thank you.
We get to the 3rd trimester, placenta previa. I alluded to the way placenta previas behave, and placenta previas can be graded as 1, 2, 3, or 4. Nowadays, we tend to call them as minor or major. And essentially a major one, which is one that is encroaching over the cervix in its entirety or completely centralised. And those placentas, particularly if you pick them up on a scan at 20 weeks, they're the 2 percenters that aren't going to move, because they've got nowhere to go. If the baby's growing up all around you, but the placenta is stuck there, it's very hard for the cervix to pull away. So ironically, those bigger ones, as a general rule, tend not to bleed as much at the time of the pregnancy as it goes through to full term, but they're going to need a caesarean section, because it's the old analogy of a cork in a wine bottle. You can't get the baby out when the cork's in the neck of the bottle and the placenta is now blocking the cervix. Those slightly lower grade placentas, the ones that are sitting near the cervix, they're the ones, as they're pulling away from that vascular cervix, and they're the ones that can sometimes bleed, and that can be minor, major, and they're the ones that, or any bleeding with placenta previa will require admission. And the complexity of care for placenta previas is always going to be, when do they come in? Will they always come in? How long do they have to stay for? Is it 1 day, 3 days, 5 days? Is it like the old days where they stayed in for the rest of the pregnancy? What if there's been a previous caesarean section? It's an anterior placenta previa, and therefore there becomes a risk of invasion into the scar, so increta, percreta, excreta, so going out of the uterus and going into the bladder, the broad ligament, etc. And that is significant, and we've had some really catastrophic Caesar hysterectomies for planned placenta previas for patients over the years. And a famous story a few years ago of a woman who, with the 3-time replacement of her blood volume, drained the entire blood bank of Victoria that day and lived, thankfully, because of the amount of bleeding associated with her previa. Abruptions, once again, for various reasons. Threatened premature labour or actual premature labour. So the differentiation between when someone is presenting in actual labour, so contracting and dilating prematurely, which is under the 37th week, and obviously worrisomely if it's under 32 weeks, or someone who presents with what looks like suspicious threatened premature labour. But the point to make is that sometimes you can get some cervical effacement, so shortening, cervical dilatation, which of course can lead to bleeding. A show, the operculum plug. Essentially, when the cervix is ripening in late pregnancy in anticipation of the onset of labour, we don't understand what the mechanism of that is even to this day, but it happens in multis particularly, and certainly in primibs, there'll be a passage of a plug, and that plug, the operculum, may be, because of the vascular nature of the cervix, it may have some blood in it. And we always tell our patients not to worry when they see a bloody mucousy plug, unless, of course, there's a significant amount of volume as per whatever they would determine that to be, in which case they would call the midwives in birth suite for some guidance. Cervical congestion, once again, can haunt women all the way through to the end of the pregnancy. I put here vasopresia, an absolute emergency. Vasopresia is where you have a blood vessel on the fetal side of the placenta, which is, of course, then going to go into one of the umbilical cord vessels, which can then, of course, be a direct conduit from the baby. And if we remember that as humans, we have 80 mils of blood per kilo. So a baby born at 3 kilos has 240 mils of circulating blood volume. Now, it only takes you 10% of your blood volume lost to be shocked. So for a baby, that's 24 mils of blood before they become shocked. So if you have a vasopresia, whether it be in whatever capacity it is, and the cervix dilates up, the membranes rupture and ruptures through that vessel, that baby can lose 80, 90, 100 or so mils of blood very quickly if you think about how little that actually is. And that can have a catastrophic effect on the baby. And one of the dilemmas that we have is managing women with known vasoprevias in, do they need to be admitted, at what gestation, and when do they then need to be delivered, which would be by caesarean section. And we actually have, again, all these anecdotes, another patient on the ward at this very moment with that same problem. And we have ways of managing that based on their parity, how their cervix is, how close they are to the hospital, presentation of the baby, past history, et cetera, et cetera. But it's not, again, a one-stop-fits-all sort of approach for these sorts of problems. Once again, local pathology, and once again, haemophilia or blood disorders as causes of bleeding. So we get to the importance of what we're trained as doctors, history and examination. It's always paramount in terms of providing good care. And when I say that, and, you know, abdominal palpation, obviously fetal heart checks, blood pressures, etc., all, again, all gestationally appropriate. Internal examinations, be it by manual or with speculum. Ultimately, investigations, and absolutely, as I spoke before, ultrasound are really the key to assessment of what's going on, particularly if we're focusing on fetal well-being. But of course, there is, of course, the other investigations that would be appropriate for the maternal health. And this is alluded to in the cases of extreme bleeding. So the significant abruption, the placenta previa bleed, where we need to practice, you know, the principles of, you know, ABC, airways, bleeding, circulation, hemorrhage management, you know, blood replacement, grip and hold, et cetera, et cetera. So we have a very strong principle in obstetrics that the mother's health is our priority, the person who is here in front of us. Obviously, we do our very best to protect the baby as well, but the mother always has to come first. That is our priority. In the first and the early second trimester, as much as the volume of loss, pain or no pain, and any pregnancy symptoms you have, like feeling like you've got ongoing nausea and vomiting versus I've had a complete cessation of all of my symptoms, all of these are useful indicators, but not necessarily always reflective of the outcome. So you can have a painful bleed, a moderate amount, maybe 100 mils or so, at 12 weeks gestation, and the pregnancy may still be okay. You could present at 9 weeks gestation with just one little bit of brown blood, no pain, and still have pregnancy symptoms, and you could have a 9-week blighted miscarriage on board. So as much as pain is never a great sign, and heavy bleeding is never a great sign, and losing your pregnancy symptoms is never a great sign, they're not absolutely predictive. And so ultimately, when we talk about, on a slide to come up, about investigations and doing beta HCGs and et cetera, ultimately, is the woman in front of you safe, her vital signs, her general being, no signs of an acute abdomen, the amount of bleeding she has, is the woman safe? And then ultimately the scan is going to be a very key part of your care, as much as examination is useful, and knowing when to do a bimanual versus maybe doing a speculum. Speculum particularly useful because it protects against, if they've got a placenta previa unexpectedly, you're not pushing your finger through. If they've got bulging membranes into the vagina with cervical incompetence, you're not potentially going to pop them. It allows you to see if they've got a cervix open or closed, actually see it rather than just feel it. And it's also good to see if there's a cervical tropion. So generally speaking, when it comes to examination in the vagina and pregnancy, outside of doing vaginal examinations in labour at term, obviously to assess progress, speculums would be probably the preferred choice instrument. Persistent bleeding, how heavy it is, will obviously pose problems on, just say you have a woman and you've just seen her in the rooms and she's had some bleeding and you sensibly got a scan for her, and the scan shows that everything is great. 8-week pregnancy, cervix long and closed, maybe a 0.5 centimetre, 1 centimetre extra chronic clot. And then she rings you up the very next day and says, hey, I've just had some more bleeding. Are you going to scan her again? How often do we need to re-examine and re-scan our patients, and when do we need to admit them? And generally speaking, admission is obviously for the later gestations, for previas, for abruptions, for cervical incompetence, for prematurity risk. That's when you admit. The admission for a miscarriage wouldn't be appropriate other than if the woman is coming in because she has miscarried and is going to need to have a procedure or something involved to extract the fetal tissue. And again, I alluded to at the bottom to really try to use a speculum mostly if you can, because of some of those things that I mentioned. Investigations, and really this is elaborating on what I've just said. Ultrasound scan and its accessibility nowadays, and fortuitously for me in obstetrics, where I have coincidentally 2 in my rooms, is really paramount to how we can really properly assess how the fetus is going. I understand that's obviously not something that's easily accessible in general practice, and also the ability to be able to provide your patients with easy access through radiology services, but that would be the best thing to do. So in the first trimester, as I said, where is the pregnancy? Is it in the uterus? Is the pregnancy consistent with dates, particularly if you have a regular cycle and we expect that? Do we have a singleton or a multiple? And of course, I mentioned triplets earlier. We assess for a fetal pole and viability. Is there a fetal heart? Do we look at the sac and the cervix? Is the cervix closed? Is there an extracoronary sac? Does the sac look disorganized? And are there the classics of what we call snowstorm appearances of a GTN, gestational tractoplastic neoplasia, a molar pregnancy? And I'm actually delivering a woman on Friday, but when I looked after her first pregnancy over a year ago, she actually had a molar pregnancy, which is really bloody annoying because, of course, once they get their beta HCG loads out of the way, they have an obligatory amount of time they have to wait before they can get pregnant again. So it's going to be a very special day for her Friday when, after all these years of trying and then a mole, she's going to have a baby. The second trimester, again, assessing viability. Where's the placenta? Is it a placenta previa? Are there any concerns with the baby, fetal anomalies that might be suggestive that maybe there's an underlying problem which might be accounting for why we're bleeding? The length of the cervix. Very, very, very important, the length of the cervix, because cervical incompetence is something that we do see more of. I mentioned the triplets earlier where they lost that pregnancy. I placed a stitch urgently the other day in a woman who had an unexpected short cervix on a morphology scan with no risk factors. Cervical length is a really useful piece of information for us. And in the third trimester, once again, placental location, signs of abruption, placental separation, signs of imminent delivery. Is the baby appropriately grown for gestation on centile curves? And we do a biophysical, so check the AFI, the ST ratio. We might do a little simple artery, ductus venosus if necessary, look for fetal breathing movements, fetal movements itself, essentially scoring the baby's health. I see a lot of women, and I totally understand why they're ordered getting beta HCGs done quantitatively and getting them done every second day, looking for the classic double dilutional rise, and also looking at a progesterone level relative to what you would expect for a rise in pregnancy, and see that investigation done. And I never say to the patient nor to the GPs, don't do them, because they're safe to do. Hopefully the patient's sake, they'll be a bulk build. And it's a relatively minimally invasive test. But essentially with a beta-HCG, unless it's falling or not rising to the satisfactory rate that you would hope for, without the ultrasound scan, you don't actually ultimately know if it's a mole or inevitable or progressing or not. So I don't say don't do them, but I would personally in my private practice, and again, because fortuitously I have the scan available, I would always just scan my patients. That's what I'd be doing. But a lot of women in early pregnancy, in that lead up from the 3.5 week, where they can do early awareness tests for, oh, I'm pregnant, urinary pregnancy test comes up positive, so the sensitivity of those tests, up until 5.5 weeks where you cannot see a fetus properly on a scan, if they've got some early spotting, some implantation bleeding, and they're worried, I guess the beta-HCG can provide them with that reassurance that they're looking for until they can get a formalised scan where something will actually be seen, which is usually at 6 weeks gestation. So that may be a place for doing them, but beyond 6 weeks, personally, I think a scan is the key.
Peter, there was a question about, do you always do a speculum examination for bleeding in the first trimester?
Very good. So in my practice, because I have the ability to do vaginal probes, what I will do is I'll do a vaginal probe so I can see the length of the cervix and I can see the gestational sac more clearly. If it's around the 8 to 10 week mark in the pregnancy in a slim woman, I'll do an abdominal scan where I can get a sense of what's going on with the cervix. But that would be a situation where if I was worried, the speculum is useful because when you see an ectropion, it's almost like a reassurance. So if the baby looks well and there's an ectropion, you can have a fair degree of confidence that that's the cause. And because you've visually seen it, because you won't be able to see that in the scan, you can say that to the patient. So when we talk about good care, history, examination, investigation, I think a speculum is a useful thing to do. It only takes 30 seconds. And once it's done, then with the ultrasound scan, you've got a very, very good way of being able to guide your patient what's going on. Yeah.
Could I just interrupt? There's been lots of questions about name changes, that people are struggling with their name change. If you could just ask Selena directly and just let her know what the current name on the screen is and what you would like it changed to, I think that Selena can sort that out. I'm just going to ask another question, which leads to one of the questions I was asking before, which is, how is progesterone levels in pregnancies interpreted? Are progesterone levels useful at all in pregnancy?
Okay.
And then that...
Yeah, look, it's such a great question. And when I started my training many years ago, there was no use of progesterone in early pregnancy assessment. And then when I was gradually sort of drifting down through the emerge department in my subsequent years as a consultant seeing patients down there for the trainees, and I'd see the progesterone level charts up on the ward in the emerge department. And I always used to look at them, and I'll be honest with you, with my years of clinical experience, ever so slightly baffled as to the relevance of how helpful they would be, because really the key to the pregnancy is the beta-HCG and obviously whether the pregnancy is viable. The issue with progesterone and its use in any aspect of obstetric care is particularly with IVF and the questionable value of using progesterone support if you're going to provide supplemental progesterone for someone who you perceive has got what we call a genuine luteal-based defect, so a very short last half of their cycle. So it wouldn't be last half, it'd be last third, last quarter, very, very short time from ovulation. And there's a belief that that progesterone supplementation is going to enhance the decidualization of the lining of the uterus for that early implantation until the placenta establishes itself. But when you look at good evidence for the use of progesterone as a marker and also progesterone administration beyond the IVF, it's got, I guess, questionable validity. And I see a lot of patients, sadly, with recurrent miscarriage, where gestational assessments of the fetuses that they've lost, the pregnancies they've lost, have come up as genetically normal. So they weren't genetically abnormal miscarriages. And you run a very significant profile on them, autoantibody, thrombophilia, hormonal markers, etc. And you'll get a hit rate, but often you'll have no hit rate. And then you start getting into the contentious issues of doing lymphocyte subsets, natural killer cells, both systemically and in the uterine as uterine scrapings. And there are some colleagues of mine out there, and again, you can look up the evidence and chat with them, where they have some very interesting therapeutic approaches to treating that, those conditions with intralipid and high-dose steroid and so on. And I guess the trick in answering questions of this nature is that when you practice evidence-based medicine, you have to practice with evidence. And that's the problem, is the evidence doesn't really say that there's any real benefit. So if you've got a low progesterone level in a pregnancy, is it because the pregnancy is no good and you're just giving hormone to a pregnancy that's no good, if that makes sense.
Thank you.
So I mentioned CDGs. You would really never do a CDG before the 23rd week because the fetal autonomic nervous system, the sympathetic parasympathetic nervous system, which is what drives the fetal heart rate and helps to us interpret, hypoxia and fetal arrhythmias and so on. Really, under 23 weeks, it would be a waste of time. And really, how to interpret those CDGs under 28 weeks because of those autonomic nervous system problems. But a CDG is something that we would always obviously consider, or you can just do a straight Doppler. We need to remember to do a blood and antibody screen, so looking for, O, A, B, etc., and whether or not there are rhesus positive, rhesus negative. And then obviously in the situation where you've got a really significant bleed, you need to think about the ABCs and, FBE coagulation, Clyhauer, etc. And I'll talk a bit more about Clyhauer at the end when I do anti-D at the very end. So prognosis and management considerations, which in some respects is provide us with a couple of little sort of case points to sort of reflect on, and probably more at an advanced stage in pregnancy care where this would be beyond the remit of a GP and more of an obstetrician, but still things to think about. The point to emphasise once again is not all bleeding in pregnancy will lead to an adverse outcome, and most mothers and babies will be well. A placenta previa bleed will usually settle. Most abruptions will not be severe. A lot of bleeding in early pregnancy will not lead to a miscarriage. So we need to remember that. Again, as a symptom, heavy bleeding and painful bleeding is always going to worry us. And when you're, as a GP, working out when and when not to send into hospital, send to your obstetric colleague, when to get a scan done very quickly, heavy painful bleeding would certainly be a prompt. If you have a scan, as I alluded to before, at 10 weeks, showing all is well, will the baby still be well in 2 weeks? So what if you bleed every single day for the next 2 weeks? Will you be scanning the woman every day or every week or every second week? When do you tell that woman, look, you better come straight to hospital, or look, you know what, you've had a bleed at 2 in the morning, but you don't need to call me at 2 in the morning because I scanned you yesterday and it was fine, and I bleed at 2 in the morning, we're not going to do a scan at 2 in the morning. So how do we know whether the bleeding, when it is an extrachorionic bleed, is absolutely reflective of just a little gestational sac issue, or in actual fact, the baby is putting its hand up and saying, I actually have Turner syndrome, and you're going to find that out when you do the NIPS test, which is going to come back in a couple of days, but I'm causing some bleeding now because I'm actually genetically abnormal. When is mucousy pink loss at 18 weeks? Congestion from the cervix, or the worrisome condition of cervical incompetence. Cervical incompetence is a really challenging diagnosis, and I tell all my trainees from the 16th week to the 22nd week of the pregnancy as a bare minimum, when a woman bleeds, just say if they ring you up and they say, I've just had some scant pink loss, and that's it. No pain or no nothing, just scant pink loss. And they ring you up at 4 o'clock in the morning. I would tell that woman to come in straight away, because fortunately, it'll be a disruption to my sleep and it'll be a nuisance to her. And fortunately, when she comes in, the cervix will be long and closed and the baby will probably be fine. But if her cervix is opening up, and that's the reason why she's got that bleeding, my immediate attention to that, Trendelenburg, the addition of progesterone PV or PR, a conversation about whether or not we should place the stitch, doing a swab and starting antibiotics will provide a vastly different prognosis to if I said to her, you've just had a spot of blood, it's only a spot, you're not having any pain. If it doesn't happen again, it's probably okay. And then 1.5 weeks later, she presents 4 centimetres dilated with an effaced cervix, and then we've got a very difficult problem to fix. So that particular issue is a problem for us, particularly if it happens on the weekends or at night, because it's just shitty timing. But it is what it is. And if you're going to provide good care to patients, you would always be alert for that possibility after the 16th week, gravitating through to, it can actually go up to about the 26th week as a diagnosis, but certainly from that 16 to 22nd week, I'd be very alert to it.
So just to recap there, looking at cervical length, consider having a conversation about whether you put stitch in if it's very short, also considering vaginal progesterone and the swabs. And I was just going to ask what happens when you pick up ureaplasma in one of those swabs? Sorry to ask a hairy question.
Oh, my lordy, yes, thank you very much. So the question, of course, is going to come down to the amount of ureaplasma that's picked up. So what looks like really like a contaminant load versus like profuse. And then, of course, circumstantially to what you're dealing with. Are you dealing with cervical incompetence, or have you done a swab on a woman who's got a cervix that's 2.5, 3 centimetres? Vastly, vastly different. One of the challenges with answering this question, this is something I'd never forgotten. I went to a brilliant talk many years ago by one of England's leading MFM specialists talking very specifically about cervical incompetence. And in England, their cutoff markers for cervical incompetence are 0.5 to 1 centimetre longer than ours. So in other words, they are shorter, than ours. So they're actually much more tolerant of a short cervix than we are. And I was listening to the way that his expert unit practices their provision of care, and there's articles that he's written. He's the beans when it comes to talking about this topic. And I said, oh, do you do swabs? And they said, oh, no, we don't do swabs. I said, so you don't use antibiotics? I said, no, we don't use antibiotics. I said, what happens if one of your registrars took a swab and there's ureaplasma profusely? What would you do? And he said, oh, I'd treat it. I mean, how do you then as a clinician learn from that when he's really contradicted himself? He won't do the swab, but he would treat it if it was done. And it was abnormal. Yes. So I think the answer to your question, and I think it's in fairness to you, if you were ever to do a swab on a pregnant patient, you pick up a bacterial vaginosis, profuse concerning anaerobic sort of findings, mycoplasma, ureaplasma, I don't think it would be unreasonable for you to just seek a second opinion and allow us to make the difficult decision for you, because even we are, as I've just alluded to, not necessarily 100% what is the best answer.
And certainly, I've had a few GPs ring me in the past because our policy is not necessarily what we do. It is a fairly individualised, clinician-based approach. There is a question that I know the answer to, but I thought I'd ask it, which is is there a role for aspirin in recurrent miscarriages or heparin?
So again, you could spend hours on the topic. With recurrent miscarriage, when I have a patient, obviously there's diagnostic specific therapy, and then there's the clinical conundrum of the patient who's had a few miscarriages and your investigative workup has found nothing, no translocation defects in the parents, no hormonal, no autoimmune, no thrombophilia. And you haven't gone down the pathway of more contentious testing, lymphocyte subsets, natural killer cell scrapings, etc. In those women, low-dose aspirin is innocuous. We certainly recommend it for our advanced maternal age patients, our overweight patients, our multiple pregnancies. And there's actually some question as to whether or not maybe therapeutically in the future all women will get it, because it reduces the risk of preeclampsia and so on. So low-dose aspirin would definitely be a very safe option to use, throwing mud at a problem which is safe, because you're not sure what you're treating, but you're certainly providing a potential benefit. There's benefits in the use of vitamin B3 in miscarriage prevention. So vitamin B3 should be considered either as a specific vitamin B3 or a B complex addition. And that's just something you can look at. If you're looking at the whole antioxidant issue in terms of free radical scavenging and so on, the best antioxidant on the market would be coenzyme Q10 if you're going to use one. So coenzyme Q10, B3 and aspirin would definitely be worthwhile. You can chuck progesterone into the mix, but again, I've alluded to the fact the evidence isn't absolutely supportive. And then when you start to, as clinicians, look at things like clexane, steroids, doses of steroids, and so on, is going to come down to your interpretation of other data.
There's one thing that I had happened to me this week, which was a woman had a 12-week scan, cervical length was 4.5 centimetres or something. It was perfectly fine. And at 20 weeks, 21 weeks, it went down to 3 centimetres. I wasn't worried at all, actually, but the recommendation was to rescan her in 2 weeks. Is that something that, do people look at the trend as well, even though it was well normal, being above 2.5 centimetres?
Look, I think it's always one of those questions where the full clinical picture and who did the scan is relevant, parity and so on. 3 centimetres is still
there was no risk factors involved. Yeah. It might have just been a very cautious ultrasonographer.
And look, what? There's no harm in doing that, but 3 centimetres prognostically is an excellent cervix, and that shortening of cervix of 1.5 centimetres or so would be probably gestationally appropriate.
Thank you.
Yeah. When the placenta previa bleeds, and if it's a little bleed or a heavy bleed, do they stay in for a day, a week, a month, or to the end of the pregnancy? And we, again, will often, there is no textbook answer, and we have lots of previas. There's never been a ward service I've done in 20 years where there hasn't been a placenta previa patient or two on the ward. And we have very varied approaches to when they stay in, and it's influenced by the nature of the previa, the amount of bleeding that brought them in, how far away they are from home, compliance, etc. There was a tragic case 30 odd years ago, just prior to my starting my training, where a woman went to the bathroom at the old women's hospital and locked herself in the bathroom to go to the toilet, had a catastrophic placenta previa bleed and couldn't actually open the door, was trapped in the bathroom and bled out in the bathroom without being able to access help. So they can be like a tap and really catastrophic. And so therefore, because we worry about that, we have to worry about where our patient's going to be in case that happens. Is the small bleed a trigger bleed for a big bleed? If a person has an abruption, once again, how long do they stay in? And again, that will be very much determined by the cause, the amount of bleeding, how much placental separation was, the risk of it occurring again, and so on. Can cervical congestive bleeding last the entire pregnancy? Yes, it can, because the pregnancy, you remain very hormonal, very vasodilated, and the cervix remains very vascular. So yes, you can sometimes have this bleeding patient who bleeds every day from early pregnancy to the end, and you're constantly having to make sure, your Peter Cry Wolf, that you're not missing another problem. You know it's the cervix, you know it's the ectropic, but could it be a previa? Could it be an abruption? Could it be cervical incompetence? So you're having to constantly assess your patient to be careful. When do we use steroids? Immediately or sometimes. When do we do double dose steroids, repeat doses of steroids a week later? When do we use magnesium sulfate as a protector for fetal brain? When do we need to use tocolysis to protect against contraction activity? And how can we use tocolysis safely? Because you have to be careful with using tocolysis for bleeding disorders such as previas and abruptions. We always must remember to do Kleihauers at the appropriate time, and we also need to not forget anti-D once again. And is there a chance that we might end up with a premature baby? How long can we protect that baby from being delivered? As you know, the more gestation we get, the better. And occasionally we have to deliver a baby prematurely. We have no choice because we have to do that to actually save the baby, but also to save the mother. Treatment. Treatment is going to be very specific to the trimester and the magnitude of bleeding. And one of the questions that we was asked before and allude to now is, when do you really need to look at referring in? When should you be seeing an obstetrician? When should you be getting a scan and so on? So certainly a confirmed miscarriage, definitely an ectopic, and definitely a molar pregnancy would definitely warrant some sort of specialist intervention, be it at a hospital, an obstetric hospital with a private obstetrician. Cervical incompetence is very, very critical time-wise in terms of how it's managed, particularly if you've got a length of cervix to work with, or God forbid you've got a dilated cervix and we need to protect those membranes from breaking. So cervical incompetence requires urgent review. Placenta previa abruption, always, yes, requires a review at a hospital for fetal and maternal safety. Fetal anomaly unquestionably requires maternal fetal medicine intervention to assess the anomaly and prognosis. Any bleeding after 16 weeks, because I mentioned before, cervical incompetence is a risk, and particularly at viability, when you could deliver a baby at 23 weeks, not that you wish to, and that baby with our advanced neonatal intensive care resuscitative capacity, we could protect that baby and keep it alive. Obviously, no guarantees on long-term health of the baby in terms of brain, respiratory, eyes, etc. But nonetheless, at 23 weeks, if there's a risk of delivery, that needs to be managed. Excessive blood loss, obviously. A hematological disorder, obviously. And once again, if you're not sure, just refer. We have a fantastic service at the Women's where I work. In our private practices, I will always see someone. I would be seeing at least 2 women any given day, even on weekends sometimes, with problems with bleeding or whatever, that just can't wait. So if you're not sure, call on a colleague, a friend, someone that you're used to speaking with, and or send them into hospital. Specific treatments. In general terms, a normal looking pregnancy which is complicated by bleeding is managed with reassurance and home. So threatened miscarriages, we use that nomenclature. Everything looks okay, cervix long and closed. Reassure, say we're not sure exactly where the bleeding is from, we're not sure if it's from ectropic or whatever, but the baby seems fine at home. For miscarriages, we would look at the option of a curette. Usually there is, of course, the conservative approach, but a curette to expedite, and a laparoscopy versus methotrexate to manage ectopic pregnancy. And the differentiation between the use of the two would be as per what is best for that particular situation. And for a ruptured ectopic, it would always be surgery. And for smaller ectopics, it could be using methotrexate. The management of cervical incompetence is very specific. It's beyond the remit of the talk, but we have very specific processes for that, and particularly when to insert a suture. Placenta previa would always involve an admission, and then the question, of course, of length of admission. And then we would usually do a group and hold early on, and then the option of steroids if we're concerned about the baby's gestation and risk of prematurity. And again, once again, the same with abruption. Always admission, and then working out how we can make sure the baby and the mother are safe, steroids, cross-match, and so on. Tocolysis, again, needs to be used cautiously. Tocolysis options, of course, include things like nifedipine loading, bricanol, so options of that nature, even GTN patches. We don't use intravenous Ventolin anymore. And these can be considered depending on the situation and whether or not it's appropriate for the bleeding that's occurred. Steroids, magnesium sulfate for neuroprotection, steroids, of course, for lung maturation, and blood transfusion, of course, for the patient. And we even have patients where they have placenta previas and they're bleeding, and we give them a blood transfusion, the bleeding settles, and we keep them pregnant. So we're not necessarily having to deliver them straight away. And as I come towards the conclusion of the talk, and thank you for your patience, I'm just going to talk.
Just before we start, yes. There's a question here about sort of if the woman has a confirmed miscarriage but wants to avoid an D&C, how long can she safely wait to hope for an actual complete miscarriage? As a GP, usually, it's interesting to see if we're the same. Mine is usually thinking, 8 weeks. At about 8 weeks, less than 8 weeks, women can generally, 8 to 9 weeks have a natural miscarriage, but over that they tend to often require intervention. But what's your thought about it?
So I think it's a notion of informed consent. So if a person presents at 9 weeks and they've got a 7-week missed abort, you can say to them, well, this pregnancy failed 2 weeks ago. So already 2 weeks has passed and nothing's happened. So are you willing to wait longer? And a lot of women will say, well, if it's been 2 weeks and I haven't miscarried, then no. There are other women who are presenting with some bleeding, and there's a better than average chance that bleeding is going to escalate. And if they're comfortable with managing the blood loss and the discomfort that occurs, remembering it's very rarely life-threatening, and that can be managed at home.
So it's quite a variable point.
Absolutely. There are some women who, I guess, if with the safety of contemporary surgery and anaesthesia, the ability to do a safe dilation, evacuation with a suction, they feel like the fact that they can come in, have that done, and they go home, and with almost few exceptions, there's no risk of perforation, retained products, infection, bleeding, and then they get a recovery period within 4 to 6 weeks, they can start trying straight away. And if they ended up waiting for a conservative approach that goes for 4 to 5 weeks, that can be quite bloody and painful when it happens, and God forbid incomplete, then they're delaying their recovery. So I say to people very honestly, there is no one size fits all. It's about what you think is best for your circumstances. Probably, I'd say on average, I'd get probably 60-40, 70-30 split where women are electing to have the curette, particularly for a missed abort or blighted, because they just want it to be sorted so that they can get on with trying to conceive again.
At what gestation, from a fetal point of view, is it more likely that that you'll get an incomplete abort and therefore actually
with advancing
requiring them? Yeah. So is it about sort of 8-9 weeks?
8 to 10 is obviously the grey zone, and after 10 it certainly becomes quite like you will not enjoy the cervical dilatation. It will be painful, and it can be quite confronting blood loss, although very rarely will be life-threatening. And to deal with that is the reason why we only use mifepristone for the abortifacient, RU486. Only at very early gestations, because beyond that it becomes just too difficult at home. Yeah.
Thank you.
So anti-D prophylaxis, very quickly, the fetal blood cyst develops quite early, and we know that the average Caucasian is going to be Rh negative in about 15% of cases. Ironically, Asian and African American women less than 1% of the time, so we won't see very many, particularly if they're an interbred couple, you'll be having anything other than a positive blood group. And because of the homozygosity and heterozygosity of how we develop the blood protein, we know that about 70% of women who are Rh negative are going to have an Rh positive child. Okay, so whether they've got a homozygous or heterozygous partner, they of course themselves are rhesus negative, can then lead to 70% of the offspring being positive. Generally speaking, from the 6th week of the pregnancy, we will usually offer anti-D to a rhesus negative mum. Institutional guidelines can vary, and the women's, for example. So because we're talking about day 38, and of course, if your maths is good, that's about the 5th to 6th week where there's blood. But really, the reality is that the amount of blood that you actually have circulating that would be really realistically able to cause an isoimmunisation event would be not until about the 8th week. But there is actually data to say that 0.2 mils of fetal blood, if it's rhesus positive, can isoimmunise a woman. So if only 0.2 mils of blood happens to leak out at a miscarriage at, say, the 7th week, then there's a teeny tiny chance that a rhesus negative woman could isoimmunise. So we usually offer 250 international units of anti-D for a woman under the 14th week, 625 international units after the 14th week. And this is in the context of a failed pregnancy or a bleed in a rhesus negative. Okay. Now, how it works is that the blood protein, the red blood cell has got protein spikes coming out of it. And if you've got rhesus D positive protein spikes, you're rhesus positive. And you are, with your rhesus antibody screen, you'll have, obviously the antibodies that will be able to, detect that blood group. And we know that when you give anti-D, what happens is the anti-D, which is essentially antibody, attaches to the proteins, which is fetal blood cells in your maternal bloodstream. And then they get taken out through the reticular endothelial system and essentially mopped up, okay? And one shot of anti-D, 625 units, can mop up 6 mils of fetal blood. So what that means is we need to do Kleihauers at later stages in the pregnancy, because if you have a Kleihauer and the intramaternal bleed of fetal blood was 9 mils, then you would need to have 2 shots of anti-D. If it was, 18 mils, you need to have 3 shots of anti-D, because you need the amount of D to mop up all of those blood cells for fear of then getting an isoimmunisation event.
One of the things, Peter, that's come up twice in the chat and also confuses me, and you might not be aware of this, but you probably are, is that the recent blood guidelines have actually suggested for medical termination of pregnancy, because that's a common procedure in general practice. It happens under 63 days. So under 9 weeks, that anti-D is not required in that circumstance.
Yeah,
whereas
and look,
for miscarriage, it sort of is incongruent.
Yes. No, I'm aware of that because it was discussed recently at a team meeting, and I think if you're practicing institutionally with the clinical practice guidelines, you have to follow institutional guidelines. I guess all I can allude to is that I had some fantastic mentors in my training who alluded to these very anecdotal cases, and you should never practice medicine with anecdotes. But if you do have a patient who was to miscarry and was to isoimmunise at an early miscarriage gestation or have a termination and isoimmunise, that's a forever outcome. It will affect transfusion in a motor car accident. It'll affect all her pregnancies in terms of reisoimmunisation of any rhesus positive baby she might have. So if we know that blood is screened well, because it is a blood product, and the risk of, obviously hepatitis, et cetera, is extremely low, 0, then I personally am surprised that, up to such an advanced gestation, they wouldn't give it. But I understand that they've obviously got clinical data that supports that, and I can't refute it. Yeah. And the last paragraph of the talk is really just that commentary about if you've given anti-D, and the reason why we give prophylactic anti-D at the 26th and the 32-week mark is for those silent intravascular bleeds from the baby that can lead to an isoimmunisation event, and the anti-D mops that up. And if you've been given anti-D within 6 weeks of the last dose and you have a negative Kleihauer and you have another bleed, the anti-D that you were given a few weeks earlier should be able to mop up what, blood might be present in your circulation.
So that's so at a practical point of view, that's really hard in general practice when people keep bleeding. So what you would do is do a Kleihauer. How often in that circumstance?
Again, I wish I could answer that with a black white answer. It's the one size fits all. I mean, Kleihauers really generally, we actually tend to use them sparingly now. And we do actually flow cytometry rather than an old-fashioned Kleihauer, because an old-fashioned Kleihauer is actually counting red blood cells on a fetal slide using a computer. It's quite an antiquated way of doing it, although we do it. Fetal flow cytometry is the better way to do it. But I think if a woman is presenting with just some spotting and, you wouldn't need to be doing a Kleihauer all the time with that. But if a woman has quite a significant bleed and not necessarily a placenta previa bleed, where you're looking at maternal bleeding, you're talking about an abruption perchance, where then you would be definitely considering repeating the CLIHAL. But I think in fairness to you, in a situation like that, you are always welcome to get some advice from the women's, from one of the registrars, from a clinician like myself, etc.
Thank you.
And I've just put up the last slide with just some resources that you might be able to access, and there are obviously a dearth of resources thanks to the internet and Google, but these are just some of the ones that we would advocate in terms of the quality of the information. And I thank you for your time.
That was absolutely terrific. I learned so much, Peter. I'm just going to see if I've asked lots of questions along the way, which I think was great. And I'm just seeing if there are other questions to ask. Selena has put up on the chat the survey. I have got people, I think that all names have been sorted out, and I'm just seeing if there's any other chat questions to go. I don't think there are any other questions. Is there anything else that you wanted to cover, Peter?
No, look, I hope that was comprehensive enough, and I think we all understand that there isn't not a one-size-fits-all answer to prognosis and management, but the support services that we now have available in contemporary medicine and secondary, tertiary level teaching hospitals, maternity hospitals, private practice, easy access mostly to even some bulk bill related scanning out there. We've got a dearth of things available, but always ask. I have GPs ring me up all the time. It can be like a 2-minute phone call. It's never it's never an imposition. We're scratching each other's backs along the way, and if you need advice, you just ring, and if we're not sure, we'll see the patients or recommend.
Great, yeah, and that's right. Just ring us at the Women's, drop an email to me at ines.rio@thewomens.org.au. Obviously, I won't be able to answer on the day for those immediate things, but for things that can wait a few days, ring the registrar on call at 8345 2000, ask for the obstetric registrar on call, and often you can ring the ED department and get some advice as well. Health Pathways is fantastic. Also, there's other resources are there as well. And there's lots of thank yous on the chat. So once again, thanks, Peter. Thanks to everyone at Northwestern Melbourne Primary Health Network, and thank you for attending today. Have a lovely evening.
My pleasure.
Bye.
Thank you.
Thank you. Bye.